It is my great pleasure to introduce Professor Urszula Foryś, my colleague from the office just directly above my room. In the pyramid of affiliations, she's a professor of the University of Warsaw, Faculty of Mathematics, Informatics and Mechanics, and Institute of Applied Mathematics and Mechanics, and the section of game theory and biomathematics. And actually, she is director of that section. Urszula Foryś is dynamical system person. One of her specialties is the differential equations with time delays. So these are infinite dimensional dynamical systems because ordinary differential equations map points to points along the trajectory. And here we have to have initial conditions as functions of the past. So differential equations with time delays map functions into functions. But she's not just investigator of theoretical aspects of differential equation with time delays. She applied this to biology and medicine. And she was inspired by the guru of dynamical systems, her teacher and promoter, Wiesław Schlenk, who introduced first dynamical systems into Poland, and then mathematical biology. So as we'll see, she applies dynamical systems in biology, medicine, specifically in epidemiology, and today will be devoted to oncology, mathematical oncology. Urszula Foryś was the president of the Warsaw branch of Polish Mathematical Society. She's the vice president of the Polish Women in Mathematics. It is official translation. And for many, many years, she organizes the conference on applications of mathematics to biology and medicine. And actually, the next 29th edition will be pretty soon in Zdynia, to the east. Well, the floor is yours, and you can.
Okay, so thank you for the nice introduction. So at first, I need to highlight that there will be no delay during this talk. Of course, this is true that my main interest is in dynamical systems with time delays, but during last time, I have found many other problems that could be solved not necessarily using time delays, and systems with without time delays could be useful as well. Another remark I would like to tell at the beginning, so the title is Mathematical Oncology: Insight into Cancer Treatment from a Mathematical Perspective. Of course, this is true that I will talk about mathematical models used in oncology. However, this perspective will be, I can say, mine, because most of the models I would like to show you is related just to my research. However, I will start from something which is generally well known. Okay, so a bit of introduction, several words. Why to study such problems. Cancer is still one of the leading causes of death worldwide. So this is the reason that scientists around the world are trying to find the answer to the question how to effectively treat cancer. Of course, there are various types of treatment. However, in clinical practice, mainly you can find two, especially in Poland, surgery, which is not in our interest now, and chemotherapy, which is the main topic of this talk. And there are many other therapies, including various types of immunotherapy. And at the end, I hope I will manage to show you one of such examples. What is important that immunotherapy is really a very wide notion as related to not only cancer treatment, but also other diseases. Some of such therapies are approved for specific cancers. There are many clinical trials related to various kinds of immunotherapy. Okay, and the term mathematical oncology, which appears in my title. So this is a term that began to gain popularity with the establishment of centers around the world in which scientists of various specialties, including mathematicians, working on mathematical modeling of the studied processes and therapies, started to comprehensively deal with the problem of cancer. And what is very important here, that in these centers we have in fact scientists really of various specialties. So they are oncologists, biologists, chemists, physicists, mathematicians, and so on. And all of them are trying to find how to treat cancer effectively. Only a few, three, in fact, examples more close to myself of such institutions. Institute for Medical Biomathematics in Israel, which was established and led by, still led by Professor Tzvi Agur. And this is the institute where I spent some time, and I have some papers related to various cancer treatments with the team of Professor Agur. Moffitt Cancer Center, which is the center where they have integrated mathematical oncology department. So this is probably the most prominent institution where, in fact, mathematicians play their role, where they're trying to model oncological problems and use such models for proposing treatments. And similar but not so prominent mathematical oncology laboratory in Spain, established and led by Professor Victor Pérez Garcia in University of Castilla-La Mancha. Okay, so now coming to our topic. So we start from the standard treatment, chemotherapy. And a standard goal of chemotherapy is just destruction of cancer cells. So we need to fight the cancer, so cancer cells should be just killed. So as regards mathematics, so trying to answer the question how to effectively treat cancer, one can use the approach of control theory, which allows us to find optimal solutions. So standard control theory goal is to minimize or maximize a given functional under the dynamics which is given by some mathematical model, dynamical model, taking into account external control of these dynamics. Here, this external control is, of course, the influence of the drug. Okay, and now our goal is just to combine both. So we want to use control theory to answer the question how to do this to obtain the best result in chemotherapy, having, of course, some constraints that are always in reality. And what we know that in general, again, of course, it depends on specific hospital, but typically chemotherapy is given in the following regimen that we have application of maximal tolerated dose versus no dose. So as you can probably know, mainly in Polish hospitals, we have several sequences of chemotherapy, which is given every day from Monday to Friday. Then we have a break for weekend, and there are, say, 3 sequences, week sequences, and then the patient need a rest because, of course, chemotherapy is toxic. So long application of such large amount of chemo is not good for a patient. Okay, and now as regards control therapy, so the simplest problem we can try to solve using it. So we have a model, dynamical model. So our variable is time t. In this simplest case, which describes the dynamics of some variable, let it be x, taking into account some law governing this variable, which we call f. So we obtain differential equation, the derivative of x is equal to f of x. Of course, it is not necessarily one equation. It is in general this system of equations equipped with some initial value x0. And now we want to add an external control u. So at the right-hand side of the system, instead f of x, we obtain f, which depends on these 2 variables, x and u. And now u can also have its own dynamics, but in this simplest case, we assume that it is a function we need to find to minimize or again maximize another function j of x and u, which we call an objective functional, cost functional, performance index, depending on the field where it is used. So this objective functional is now a function which depend on x, which is described as a solution of our problem, and we need to find u such that this is minimized or maximized. Okay, so the first example I would like to present is a simple example related to the chemotherapy acting on the specific phase of cell cycle. Because it is well known for many years that depending on a specific drug, this drug acts on cells which are in a specific phase. So again, doing everything as simple as we can, we use simple compartmental cell cycle model where we have a division of cells into 4 compartments, and our variables Ni describes the sizes of cellular populations in a given phase. So N0 is the size reflecting G0 resting phase, then N1 the size of the population in growth phase. Then we have the third compartment, it is S phase, DNA synthesis, and we combine the phases G2 and M, where G2 is again growth, but it is a kind of checkpoint, and then M is the cell division. Okay. So after the division, we have the number of cells doubled, and then they go again to the phase G1. And there is a flow between G0 and G1, as we can see here. So assuming that everything is uniform and goes the same every time. So we can propose the following linear system of equations that we have parameters describing the flow from one phase to the next phase, and the only feedback not from one phase to the other is from the final. So our variable N3, it goes to N1. This is this division. Okay. And when we want to include chemotherapy, which is phase dependent, we know it is somehow standard to introduce cytotoxic or cytostatic agents into the model multiplicatively. So, for example, if we use the drug that causes cell death in the ith compartment in our system, so it is equivalent to reducing the flow to the next compartment. So having these two equations that are subsequent in our cell cycle system. So in the compartment ith, which is this compartment where cells are killed, nothing is changed, and the change is in the next compartment. So instead, the flow as before, which was AI times the size Ni, we have this flow which is decreased and multiplied by 1 minus U, where U reflects the action of the drug, and it is somehow standard that in such a systems control is scaled, and typically it is scaled to have values between 0 and 1. Okay, so now we will simplify the model even more. So we take into account that the drug acts in last phases G2M. So this will be described by a variable N2. And all other cells are taken together. It is described by variable N1. So this simplified system looks like that. So we have two equations. Equation for N2 is like in the previous system. And now this flow, which should be taken in the first equation after the division 2 times A2 and 2 is decreased due to the action of the drug. And of course, we have some initial data for our system. So this is the dynamical system we want to use in our control problem. Now we need to propose some objective functional, which will be minimized in this case. So a simplest objective functional we propose is a combination of the final, so meaning after the end of the treatment, sizes of both cellular populations. So we have just weighted values of N1 of capital T and N2 of capital T, where capital T is assumed to be fixed. So say we think about treating our patients during 1 month, 3 months, 6 months, or something like that. And we want to propose a proper scheme of such a treatment depending on this constant therapy time. Okay. Maybe I should also mention that there is another kind of optimal control problems where this time t, which is the end, is also a subject of optimization. So it is not constant, but we also want to take into account this time for our optimization problem. However, they are, of course, a bit more complex, so we will fix this ending time. Okay, so the optimal control problem is to find a measurable function u, defined, of course, on this time interval from 0 to capital T with the values in 0, 1, minimizing the functional j along the trajectories of our system. Okay, so what is the main mathematical tool? The main mathematical tool is Pontryagin maximal principle, which gives us, in general, necessary condition for optimality. However, if we have linear systems, so this condition is also sufficient. So for that problem, we are trying to solve. This would be also sufficient. Okay, so in this maximum principle, from this maximal principle, we know that such a control U for which our functional J reaches a minimum can be found in the following way. We define the Hamiltonian for the system. So in this case, when J is of that form that we have only condition for the final time t, this is a product of new variable p, which we call the costate variable, and the right-hand side of our system. So minimum for J means that Hamiltonian reaches maximum in this interval for such value of the control U. And vice versa, if we would like to maximize J, then Hamiltonian should be minimized. And as I said, this is the necessary condition for linear systems. It is also sufficient. Okay, so as a result, we need to solve the following system, which we called Hamilton's canonical form of our system. So the variable of original, the derivative of the original variable is just the derivative of our Hamiltonian with respect to the costate, and the variable costate can be described that the derivative of it is minus the derivative of Hamiltonian with respect to the original variables. And this system in canonical form is equipped with the boundary data. So this is for the original variable our initial condition, and for the costate variable, this is a final condition, which is related to the objective functional J, we see that we have here these weights which are used in this functional. Okay, so we need to do calculations for this simple system. So we calculate H, which is linear with respect to U. And in this case, we can somehow easily write a condition for optimality if so we defined the function which is called the switching function and which is the derivative of H with respect to control. And for such values of 5 which are greater than 0, we have the control U equal to 0. For such values of 5 that are less than 0, we have control which is equal to 1. And of course, we need to consider the case when this control is equal to 0. We can have two situations. So either we have a single point where the control is equal to 0. And if the derivative at such point is non-zero, so we have just a switch between full dose and no dose regimen in our optimal control. Of course, we can also have a little bit more complex situation than when these both values are equal to 0. So we need then to make calculations of derivatives of higher order, but again, it is a bit more complex. So let us assume that we can expect that either phi is 0 on some interval, which is of non-trivial length, or we have this situation where which is just a switch. Okay, so for a moment we will say what to do with this case when phi is equal to 0. So of course we need to make calculations. So we calculate cost-state equations for our problem with this final ending condition. We calculate the derivative of our switching function, and what we can see that the right-hand side of the equation for the switching function depends on our cost-state variables and our original variables. So in fact, this means that this does not depend on our control U explicitly. So if we have such a case, we need to calculate the next derivative, and if, in fact, in more complex situation, we need to calculate the next and next derivative until this U will be obtained. So here we have a situation that U appears on the right-hand side of the second derivative. Why? Because we have derivatives of cost-state variable and original variables, both variables with the derivatives are present. So, for example, and the derivative of n1 depends on U, and this appears here. So U appears in this formula. Okay, and if the control appears explicitly in a formula for the Lth derivative with L which is even, so say 2 times k, then singular controls are called controls of the kth order. Okay, and to have condition for optimality of such controls, we have so-called Legendre-Krebs condition, which looks like that. So we have this derivative of the switching function where u appears, then we take the derivative of this derivative with respect to u, multiply by -1 to k, and this should be greater than 0 to have such problem, such a solution optimal. Okay, so in our case, k is equal to 1, and we easily see that taking the derivative with respect to u over the second derivative of the switching function is positive. So this means that the condition of optimality is not satisfied. Okay, so we conclude that in our control problem, singular controls are not optimal. What does it mean? This means that optimal control of so-called bang-bang type, that is, there are only switches between MTD and no-dose protocols. So it is a kind of concatenation that we have an interval where we apply maximal dose, then no dose, up maximal dose, and so on. Of course, this simplest approach does not tell us how many switches can appear in such concatenation, and this needs further study for a specific problem. Okay, so I've shown just a simple model of chemotherapy for which we used maximum Pontryagins maximum principle. We used also Legendre-Krebs condition to show that possible singular protocols, controls are not optimal in this case. Okay, so now I would like to show a little bit different example when we can expect that such singular controls can be optimal. So what we want to do? In our model, we treat all cells in one phase equally. This means that the drug acts the same on all cells. However, a common feature of many types of cancer is the ability to develop drug resistance to chemotherapy during treatment. So, in fact, depending, of course, on the drug which is used, sooner or later, we need to expect that the cellular population will become inhomogeneous, and from simplifying mathematical point of view, we can distinguish between two types of cells. There will be still some cells that will be sensitive for this drug, so the equation for such cells could be as before. However, there will be also another population of cells for which there will be almost no action of the drug. So now I would like to present. Of course, we can imagine that we are able to use the same system as before, just adding new types of cells. However, there will be still a linear system, so we can think about a little bit different approximation. So as I said, when resistant cells appears, we can consider two types of cells sensitive to the drug and drug resistant. And the simplest model in this case describes the competition between sensitive and resistant cells. So this is the reason that we can base on population models reflecting these types of interactions. And the competition model, this is just the first part of the system written in this slide. So we have two variables, N1 and N2. They are non-dimensional sizes of our cellular population. So this means that we assume that maximal tumor size is equal to 1. And N1 reflects the size of sensitive and to resistant cell populations. And now we, to this competition model, we add the action of the drug, and we allow the mutation which is known that it appears in this situation. So we have after this scaling in non-dimensional system, we have after the scaling in non-dimensional system, we have 4 coefficients: proliferation rates and mutation rates. In general, in a competition model, we have also competition coefficients. And in fact, in our study, we have considered the influence of competition coefficients. However, here I would like to show you some rigorous mathematical results we have obtained, and this was obtained to the system with without this competition, namely they are just taken equal to 1. And what is the reason from biological point of view? In fact, we have completely no idea how to interpret such a competition coefficient and how it can be calculated having some data. So at the beginning, we have started with assuming that they are equal to 1. Okay. And now what we would like to achieve, we are in the situation that during the action of the drug, some part of the population becomes resistant. And of course, in general, it is like that, this resistant population increases and this sensitive decreases. So we want to avoid the situation when the tumor is drug resistant, meaning that it contains fewer drug sensitive cells than drug resistant cells. So this is the inequality N2 greater than N1, and we want to avoid such a situation to be able to control the subpopulation of resistant cells. So we formulate an objective functional J that panelizes drug resistance cancers. So here you see on the right hand side of the new functional J, this is the standard term where we have final population of both sensitive and resistant cancer cells. Here we have additional term. So we take a derivative, integral from 0 to t with respect to what? Okay, so under the integral, we have a function which is called Lagrangian. And here we take into account the scaled size of both population just during the treatment, which of course also should be controlled. Here we take into account the amount of drug which is used during the treatment. Again, in general, it should be controlled because we are not able to use as many drugs as we want. And here we have some function g, and this is the only, I can say, non-standard part in this Lagrangian, because this and this part are also standard. And this function g is a continuous increasing function, which is related to this penalization of drug-resistant cancers. So we have parameter epsilon, and this g depends on n2 minus n1 over epsilon. Epsilon controls the steepness of g, and now what we want g to be, in fact, like this hyperbolic tangent, like we see on the picture. So these are the properties like for this hyperbolic tangent, and here you can see 3 examples depending on the steepness coefficient epsilon. Okay, and we want to minimize the functional j along the trajectories of our competition system now. Calculations are not pleasant here. You can see that even the Hamiltonian is a little bit long. However, switching function is not so complex, but now the possibility that the switching function is equal to 0 in some non-trivial interval is clear because we have nonlinear systems. So of course, for nonlinear systems, we can expect such a situation, and that again we can expect that singular controls can appear. So the question, how to find such controls, because in the previous example they were not optimal, so doesn't matter how they looks like. Okay, so from Pontryagin maximum principle, we obtain necessary conditions for optimality, that our switching function and the first and second derivative are equal to 0. And it occurs that, of course, the Hamiltonian should be optimized, but this should be equal to some constant. And using these relations, the Coste system to our original system, it is possible to calculate formula for singular control depending on our original variable n. I have tried to put it into slide, but it was so unpleasant, almost the whole slide. So I've decided not to show you. Okay, and now we have again controls of the first order here so the condition of optimality, this Legendre-Clebsch condition looks like that, and we can easily see that it is satisfied only when n1 is greater than n2. So this means that, in fact, we can expect optimality of singular controls that appear in this system exactly in the situation we want to have, that the number of sensitive cells is greater than the number of resistant cells. As results, as regards the results we obtain, so in addition to determining the analytical formula for singular control, which was our main goal, we have also analytically eliminated some optimal control structures. So we know that the optimal control structure cannot end with no dose, and at the end, for optimal control, there it is not possible that we obtain the following sequence, that we have a singular dose which ends by no dose. So here we expect that the end should be like that, that we have singular dose followed by the maximal dose. This was everything we were able to prove analytically, so we switched to numerics, and using the gradient method we obtained optimal controls with the structure which is first maximal, then singular, and again maximal. So because maximal here is 1, so 1 as 1 here. Okay, and illustration to this problem. Here we see optimal solution. So blue is the population of sensitive cells, red is the population of resistant cells, and we see that for optimal control, at the beginning we need to use maximal tolerated dose just to decrease the number of all cancer cells. Then when we are in the middle for almost all duration of the treatment, we can use a much smaller dose. This is this singular dose which we apply here, and this is because still competition between sensitive and resistant cells allows for sensitive cells be larger than the population of sensitive cells be larger. And at the end, where situation switches, so sensitive cells are not able to control resistance, we again need to use up our drug. Okay, so in addition to check the dependence of the optimal control structure on the model parameters, we made a series of experiments, still some misprints, for 500 virtual patients. That means we randomly selected 500 set of parameters from a biologically reasonable range and solve a problem for optimal control for these parameters. So we see here the results, and we perfectly see that during the almost whole duration of our therapy, we have values of the drug which are used not exceeding 40%. Most of them are more near 20%. And conclusions. In optimal control, it is very important to formulate the optimization problem, that is, select both the appropriate dynamical model and the appropriate objective functional. If we want to delay the onset of drug resistance, we should not use the MTD in the long term. Most of the time, we should use much lower doses, around 20% of maximal dose. And our results provide formal confirmation of the hypothesis behind so-called metronomic treatment, which involves administering smaller doses of the drug over a longer time horizon. Okay, so I have not too much time to. So to another problems. So now I would like to show you two models. One model is related to prostate cancer therapy for the, I can say, better case, meaning hormone sensitive prostate cancer. In that case, androgen deprivation therapy is used, and the goal here was to propose a model which will be able to predict when there will be a biochemical failure of such therapy because in practice it is known that the resistance always appears. So this biochemical failure will also appear. And very quickly, what are the problems? The first problem in such type of modeling is the following, that there is no universal law of the growth of cancer cells. So there is nothing like Newton's law in physics. So we need to decide. There are in general what are the laws typically used. So sometimes just exponential growth is used because the model needs to act only on finite time horizon. Very popular Gompertzian type of the growth from a population dynamic logistic type of the growth. So you can see here exponential and logistic are very close at the beginning, then of course in long time horizon they are much different. Gompertz and logistic are different at the beginning. Gompertz growth is much faster, and then of course they stabilizes on maximal carrying capacity. Okay, so for our prostate cancer, we were able to use clinical data from Mayo Clinic. This was the data for more than 100 hormone-sensitive prostate cancer patients. And for some of them at the beginning, the strategy of so-called watchful waiting was used, so there was no therapy, and there is we have dynamical data without the treatment. So it occurred that using this data, we are able to propose the following growth law. Here we don't have tumor cells because the data is related to one of the tumor markers. This is prostate specific antigen, and we have these levels of PSA in our data. So the law looks standardly. However, the function F is a little bit non-standard, but it fits our data much better than the standard growth laws we have tried to fit. Okay. Drug used during this androgen deprivation therapy in clinical practice eventually lead to acute drug resistance. So our HSPC evolved to castrate-resistant prostate cancer, and our interest lies mainly in the prediction of time to biochemical failure of ADT for a given patient. So here we have a sketch what we wanted to model. So we have four blocks in our scheme. The first is related to the simplified growth law, so obtained here. The second is related to the testosterone secretion, which is crucial in this disease. Then we have pharmacokinetic pharmacodynamic model for the drug, and the last but not least, influence of resistance. To model testosterone secretion, we have just searched many articles related to this secretion, and we know that we have three hormones in this testosterone path, but we have found that this intermediate LH hormone can be omitted, in fact, in our model. So we propose very simple structure of the system describing concentration of two hormones, LH, RH, and testosterone and time T, almost linear. The only nonlinearity is a production of testosterone, which is a smooth positive decreasing function. And including the drug into this system, we instead of this linear production term for the second hormone, we use the following formula, which reflects a kind of competition between LHRH and the drug. As regards the pharmacokinetic model for the drug, the mechanism of this drug release is based on polymer microspheres. So diffusion, very simple diffusion model of the drug out of the sphere was used. Simplify, radial symmetricity, and so on. So we were able to solve it, calculate the amount of the drug within the sphere, of course, integrating. So we obtained the solution in the form of the infinite sequence. Then once the drug leaves the microsphere, it is cleared from the body at some rate. So we have this equation. And again, we can using this, we can obtain the final equation for our drug within the patient body, again, clearance rate and inflow, which is related to our solution, which was previously obtained. And eventually, we propose the following model without resistance. Our growth flow, influence of the testosterone. Here we have a testosterone steady state, which is a steady state without the treatment. And in this general model, we propose functions f, h1 and h3 of some properties. However, then in numerical simulations, of course, we need to use a specific function f, which was fitted. H1 and H3 were just rational functions. And the last point here, influence of resistance. So it was done a little bit artificially, because in this model, we have no cells, cancer cells. So in fact, we are not able to distinguish between the cells that are sensitive and that are resistant for the drug. So this was the reason that we introduce additional variables, one which is related to the resistance that causes testosterone to rise in the presence of ADT. However, there is also other type of resistance which is independent from testosterone and causes PSA to rise even though the testosterone is low, and both are just linearly dependent on the amount of the drug. Okay, and this is the full system. So the presence of resistance. So here we have the influence of the first resistance, which is related to testosterone. So this is added to the term where testosterone acts on the PSA, and the second one is added to our function H3, where the LHRH competes with the drug. Okay, so we need to conclude that the proposed model is able to properly reflect possible scenarios in both cases when we have no disease, so hormones remain at their steady state and the level of PSA is undetectable, and then in the disease case when both levels and testosterone secretion and testosterone and prostate-specific antigen rise. Okay, so I will try also very briefly show you the next model, so you will be able to follow more detailed conclusions looking at my slides. maybe the only just remark that having such a model fitted to a specific patient's clinical data, we can try to propose better treatment schemes to delay the chemical failure of ADT. So meaning that we can prolong the treatment in time. Okay, and as I said very briefly, the model of immunotherapy, a kind of immunotherapy used in clinical trial for the brain tumor malignant glioma. So we model interactions between immune system and tumor cells located in brain. So here we have a scheme, and the brain is important here because we have a blood-brain barrier which does not act in the cases of other cancers and tumors. So here it was important that we needed to include in the system additional variables related to major histocompatibility complexes of class 1 and class 2, just exactly for the reason of the location of the tumor. As regards this type of immunotherapy, immune system is stimulated by external influx of ex vivo activated alloreactive cytotoxic T lymphocytes. So we take T lymphocytes from the patient, make something, and inject it again to a patient. So we have 6 variable main. 2 are tumor cells and this lymphocyte. We have 2 cytokines, TGF-beta and interferon gamma, and these 2 major histocompatibility complex systems. Okay, so it looks horrible. I have you can search the article on the topic if you are interested in, and look of the general properties of this function. All of these functions. What is again important here, we have this underlying tumor growth law. So of course we again need to decide what should be this function. And here we have just decided to use logistic one. Of course, all the functions are smooth, non-negative, have positive coefficients, either increasing or decreasing depending on the process. Okay, so the results of our modeling. So you can see here 3 examples of the results of a clinical trial which was conducted by Professor Carl Cruz in Sydney Chemo Cancer Center. It was conducted on 2 types of this glioma. Malignant glioma of grade 3, both of course are aggressive. And here we can say that it was somehow successful trial. And glioblastoma multiforme, which is the most aggressive type of this tumor, and it occurred unsuccessful. And what we can say, our model predicted that the administered total dose of this cytotoxic T lymphocytes for this GBM patients should be about 27 times to the power of 9, which is in fact clinically achievable. And the dose which was used was 12 times 10 to the power of 8. So of course, it was twofold smaller than was which was predicted by us to be effective. Okay, so we are able to find the condition for a cure analytically. Looks, but having all the functions and parameters fitted, we can just calculate. And we had this estimation for both types of tumor in this clinical trial. So here we have pictures showing estimation of time to cure for different initial conditions. And basins of attraction depending on initial tumor size and initial CTLs. Okay, so it was very briefly that we can also model another type of treatment. So last slide, take-home message. There is, of course, no universal model for predicting cancer progression and results of the treatment. However, using appropriate mathematical, again, misprint, sorry, models, we are able to confront biological hypotheses like those related to metronomic treatment with the modeling results and some kind, we will have some kind of confirmation or falsification of such hypotheses. And this is not my idea, but I have taken it from our paper with Professor Zsija Agur, that only combining all available approaches, statistical analysis, genomic, proteomic, and so on, what we have with dynamic interactions in the patient disease drug system, we will be able to fight the cancer. Okay, so thank you.
Thank you very much. Questions?
Do these people in Israel talk to mathematical doctors to calibrate the models?
Okay.
Maybe other people in the world. I mean, how is the collaboration more or less between mathematicians and medical?
Okay, so the group in Israel, in fact, consists of several persons, depending on the project they have under realization. But there is one mathematician always. Sometimes I'm also present there. There is a biologist, biochemist, and physicist, and they talk all together. They must understand each together. So they in fact have a kind of common language that they are able to discuss how to propose a proper model for the specific problem. As regards Moffitt, so again, they have this department where mathematicians and physicists are employed, and they work on again on mathematical modeling on all the specific problems, and they talk with oncologists that are in this institute. I'm not able to answer the question how it works, because in this institution, so this is a huge institution, okay? So it is completely different situation than those in Israel, where there is several persons just working together. But of course, they have, in Moffitt, they have a much better situation, because in Israel, they only can use the data from some clinics, and they work on the data they are able to obtain from another institutions. But in Moffitt, they can work together, so they can propose some schemes of treatment and so on. But as I said, I'm not able to say how it works. In Spain, they work specifically on glioblastoma. In general, they have a collaboration with several hospitals where trials on brain cancers are made. And then they try to, Professor Perez Garcia is again a person who is able to speak with medical doctors. They have a kind of more real collaboration. They try to calibrate models to the data. So I hope that they are on the good avenue to have a real cooperation.
Just a follow-up question. This is the collaboration, but what about implementation for the treatment? I mean, for real patients.
Of course.
That's
This is a very difficult problem, mainly due to ethical policies of the hospitals. So I hope that we are a bit closer to be in a situation where this mathematical modeling and so on can be really used to propose some better schemes of the treatment. But in fact, to be in such a point, we in fact need to have much more such interdisciplinary work and institutions, not only just a few around the world. That it is just a standard procedure. So I hope that in not so far future it will be possible, but now it is still just an idea. We hope that it will help.
maybe in Poland as well, yes, because all this is
Maybe.
much harder, probably, yes.
I don't know if it is much harder. I think that it is really equally hard everywhere.
Thank you. Any other questions, comments?
And so could you please go back to the slide where you had these three laws, exponential,
Of course.
logistic, and the third one, which I don't remember the name of. Yeah, Gompertz growth. So could you say something more about this second, about this Gompertz growth?
Okay, so Gompertz growth is, so this is amazing because it becomes somehow the most often used model for cancer growth. It was proposed as a model I say more than 50 years ago, 60 years ago, by Anna Lerch. She just have some experimental data on mice, and she looked through the models she was able to use, and it occurred that for these data she had, it was the best. And then it somehow, okay, so it fits, and the reason was, in fact, that in the case she studied, the initial growth was fast. Okay, so this was the reason that this Gompertz growth was well fitted to the model. But the origin is somehow from population dynamics, and it was proposed in late 90s or something like that, of course by Gompertz, just to describe some actuarial data, and it was a function. And then after many years, it occurred that it could be rewritten in the form of differential equation, and then again, after many years, it was fashionable. It started to be fashionable in tumor growth models. What is the disadvantage? Here we have this logarithm t over k. So of course this model is not well defined. Okay, so for t equal to 0, of course this is not good. We can, of course, extend because this right-hand side has a limit when t goes to 0. So we can artificially put t equal to 0 as a value. But still, the problem is that we have no Lipschitz condition then at 0. So in many cases we have problems with analyzing what is happening near 0 for the models with Gompertz growth, and of course typical standard analysis like linearization or something like that is of course not useful here. So for models with Gompertz growth we need much more care analyzing it near t equal to 0.
Okay, thank you.
Any other questions? Maybe from Zoom? From Zoom people? I don't think. If not, let us thank the speaker again.
Thank you very much.